Power of Communication, Empowering and Engaging Patients as Partners in Managing Care Decisions. This webinar is brought to you by the Alliance, which is supported by the Merck Foundation. We have a full agenda planned for today's discussion, so I would like to introduce our moderator for today. Dr. Kavita Patel is the Managing Director for Clinical Transformation and Delivery at the Engelberg Center for Healthcare Reform at the Brookings Institution. Dr. Patel leads research on delivery system reform, healthcare financing, physician payment reform, and healthcare workforce development. Dr. Patel, I will let you take it from here. Hello, everyone. This is Dr. Belinda Nelson again. Once again, I do apologize for the technical difficulties that we're having, but we're going to go ahead and get started, and hopefully Dr. Patel will be able to join us. So I want to begin today by talking to you a little bit and providing you with some information and a description of the Alliance to Reduce Disparities in Diabetes, which was funded by the Merck Foundation. First of all, the Alliance to Reduce Disparities in Diabetes consists of 5 healthcare delivery sites that are located across the country. They include such sites as Camden, New Jersey, Chicago, Dallas, the Wind River Indian Reservation in Wyoming, and Memphis, Tennessee. And they're all working to change the way care is delivered for the nation's most vulnerable populations. Now, through concentrated efforts to move beyond the clinical system and help people where they spend most of their time, that is, in their communities, the Alliance is helping to improve health outcomes for many who face some of the heaviest burdens from diabetes. And I'm going to begin by obviously introducing our panelists, but before we do that, just a little information about how you may submit your questions. To ask a question of the panel, you will type your questions into the chat box that you find at the bottom of the screen and hit enter. Now, this will send your question to me and the other panelists. You may submit a question at any time during the webinar, and if your question isn't answered during today's broadcast, we certainly will respond to you via email within the coming weeks. So I want to begin by introducing our first panelist, and we're very excited to get this started. I'm pleased to introduce our first panelist, that is Dr. Erin Kane. Dr. Kane is a family physician at the Baylor Community Clinic at Worth Street, a clinic for uninsured and the chronically ill patients. Dr. Kane is also the medical director for 2 different community health worker programs and has a special interest in the development of this emerging workforce within the healthcare system. Dr. Kane will discuss how community health workers can be successfully integrated into clinical care teams to improve patient connections. Welcome, Dr. Kane.
I am going to be talking about integrating community health workers into clinical care teams to improve patient connections. Our program was housed within Baylor Scott and White Healthcare System, which is a large healthcare system in the Dallas and Fort Worth area. And as Belinda mentioned, we specifically worked in the charitable arm of Baylor, which supports several community clinics throughout the area. These clinics help serve low-income, uninsured, chronically ill patients. And these patients have had significant difficulty accessing various components of the healthcare system, specifically formal diabetes-led diabetes education. And on a recent audit, it is not surprising that 35% of our patient population has the diagnosis of diabetes. So the goal of our program was to optimize the primary care for these particularly at-risk patients. And we did this by embedding community health workers within our primary care medical home to try to improve the patient's ability to navigate the healthcare system. Next slide, please. Our patient population for this program, which was called the Diabetes Equity Project, the demographics are shown here. And some things to highlight are that most of our patients had less than a high school education, and over 50% identified themselves as Hispanic, and that Spanish was their primary language. Next slide, please. So the Diabetes Equity Project, we used community health workers embedded in the primary care clinic, one community health worker per clinic, to help lead diabetes self-management education for our diabetic patients. These were one-on-one patient visits with the community health worker and potentially the patient's families, and it included 6 visits over a year's time. The visits were protocol-based in terms of, and I'll show you a little bit about what I mean by that, to help guide the community health worker in their teaching. But there was, of course, room for tailoring of that program for the specific patient needs. We required our workers to have a medical assistant background because they were participating in point-of-care testing and vital sign measurements for these patients. And additionally, they participated in 160-hour community health worker certification classes and achieved the state-level certification. So we're fortunate in Texas that we have a state-level community health worker certification. And they participated in the AADE level 1 training for their diabetes education. Next slide, please. But we found that the effectiveness of this program really was held within the role of the community health worker, that there is some magic about that particular role when used well in the healthcare system. These particular workers develop the role of a trusted peer because they come from the communities that they're serving. They're bilingual, they understand the environment. Patients relate to these workers way more quickly than they can relate to typically than their primary care provider. These workers also, we designed the program that these folks would be very accessible to their patients. There was frequent contact even outside of the 6 visits over that year. The protocols that our community health workers focused on centered around medication adherence, specifically making sure patients had access to affordable medicines, that they understood how to take their medicines, and if they weren't taking their medicines properly, trying to troubleshoot what the problems were, and encouraging patients to discuss these issues with their doctors. They also focused on understanding diabetes and the potential complications if this disease is uncontrolled. And they did some very specific goal setting around diet and exercise that was patient-driven. There was a lot of shared decision-making in terms of what those goals would be. And overall, they improved the patient's confidence in managing their disease, which we hope translates to long-term good outcomes for these patients. We found that this would ultimately allow the primary care provider to task shift these topics to their community health worker, and it became a very team-based approach. Of note, as an aside, we, in developing this program through Baylor, a big healthcare system, we were able to add 2 human resources job codes for the specific role of the community health worker. This has facilitated us being able to use community health workers in other areas within the healthcare system as well. So this really was setting the stage for using this workforce, which has become very effective in other areas as well. Next slide, please. This next diagram just shows this team-based approach, that of the top box, the diabetes health promoter, that is the community health worker, the patient, and the primary care provider, that this 3-part team each comes to the table with unique responsibilities and unique skills, and that working together allows the patient to have the best clinical outcomes. We also found that the diabetes health promoter, the community health worker, when they were embedded in the clinic, this built a trust between these 2 providers, the community health worker and the doctor or nurse practitioner, to allow this sharing of information to really help improve tailoring a medical plan specific for a patient, because the community health worker would really learn what the barriers were that existed. Next slide, please. We tracked our clinical outcomes, and this graph shows the reduction in mean hemoglobin A1C. So at the beginning of prior to starting the program, the mean hemoglobin A1C of participants was about 8.4. Over the course of their time with the program, it declined to 7.2. So for those who aren't clinical in the audience, this is a pretty substantial reduction. So a 1% reduction in hemoglobin A1C translates to true improvement in clinical outcomes related to diabetes. It translates to a decrease in kidney disease, eye disease, heart attacks, and amputation. So we were very pleased to see a nice improvement in this population. Next slide, please. This next diagram shows the percentage of patients within the program with a controlled hemoglobin A1C, as defined by either hemoglobin A1C under 7 or under 8. And we were pleased show that over 70% of patients achieved a hemoglobin A1C under 8 over the course of their time with the Diabetes Equity Project. And similar to the last graph, we are also pleased and encouraged to see that this improvement holds over time, that this isn't just a quick fix and then patients go back to being out of control, that they really maintain good control. Next slide, please. We used a validated survey to evaluate a patient's competence, perceived competence in managing their diabetes. And we found a statistically significant improvement in their perceived competence over the course of their time with the program. Patients felt that they could manage this disease better, and our hope is that this would translate into improved outcomes over the course of their lifetime. Next slide, please. We also looked at how this program affected hospital utilization and found that Diabetes Equity Project participants, as compared to a control group, had a reduction in their mean hospital encounters. They had a reduction in their mean hospital length of stay and a reduction in mean cost per hospital encounter. We did not see a significant reduction in emergency room use or cost. And lastly, we are working hard to develop the diabetes toolkit, and this is the website for that toolkit. It is currently up and running, but we're still continuing to add to it. This toolkit would be helpful for anybody who's interested in trying to replicate a program similar within their own primary care medical home. This lists all of our protocols in detail and has patient information, things that we would use to teach patients about their disease, as well as more detail on our outcomes. I will turn it back to Belinda. Thank you so much.
This is Dr. Nelson. I understand that Dr. Patel has resolved her TA problems and is able to connect with us now. Is that correct, Dr. Patel?
Can you hear me?
Yes, we can. I'm going to turn it over to you now, okay?
Okay, great. Why don't I do this? I had a short set of comments and slides. Let me move that to the transition so that I can get on to Dr. Peek. So thank you for that presentation, Dr. Kane. We're joined now by Dr. Monica Peek. She is an assistant professor of medicine and associate director at the Chicago Center for Diabetes Translational Research, where she specializes in general internal medicine and preventive health care for adults with a particular interest in reducing healthcare disparities. She concentrates on these efforts in diabetes care and breast cancer screening education for African American patients, and will address how shared decision-making builds trust and empowers patients to improve health outcomes. Thank you.
Wonderful. Thanks so much. Can everyone hear me?
I think they can, because I can.
Okay, great. So wonderful. I'm glad to be here. We'll go ahead and get started. Next slide, please. So before we talk a little bit more about how shared decision-making can impact trust and activate patients, I just want to make sure we have a good understanding of what shared decision-making is. And so this is the current model of how it's conceptualized in the literature, that there are 3 actual domains of shared decision-making. The first being a bi-directional exchange between patients and providers about symptoms and health status and any sort of questions that are going on around the patient's care and their health. The second is the deliberation component, and that is really where providers and patients engage in a full discussion about the pros and cons of each of the treatment options. So if there's a choice between a medication A and B and perhaps physical therapy instead, that the patient really has a good understanding of what the advantages and disadvantages are of each of those potential choices before the patient and a clinician together make a decision about what's best for that patient, given the context, skills, environment, concerns about side effects, or any other things that the patient actually may have. Next slide, please. So we understand that shared decision-making is really central to how we want to deliver chronic disease care as part of the chronic care model, having an activated patient that's really engaged with the healthcare team as well as with their community outside of the healthcare system. We know that shared decision-making is correlated with positive health indicators, so much more accurate informed consent, better control of diabetes and hypertension, and more efficient visits ultimately. We know that as the country is moving towards this idea of a patient-centered medical home, that again, really having activated patients and having a patient-centered care system, those 2 things are really sort of integrally related to the idea of shared decision-making and patient activation. Next slide, please. Next slide. Oh, gee. Whoever's working the slide, great, thank you. So our particular project, we're one of the sites that's part of the Alliance to Reduce Disparities in Diabetes. We're the Chicago site, and our project is called Improving Diabetes Care and Outcomes on the South Side of Chicago. If anyone is interested in learning more about our program, I've listed our website here and 2 of our social media outlets. Our project really has 4 key components. Next slide, please. And one of which is specifically around patient engagement. This is just a picture of a snapshot of our website about the patient engagement site. Next slide. So we do things for both patients and providers to try and enhance shared decision-making within the clinical encounter. So we're trying to activate patients, but we're also trying to activate providers so that there's ultimately the best kind of shared decision-making that occurs where physicians are ready for it and really engaging their patients, and patients are ready for it and really willing to step up to the plate. Next slide. I'm going to talk mostly about our patient engagement portion. So it's a combination of culturally tailored diabetes education as well as shared decision making, because we know that patients can't really engage in a shared process about treatment decisions if they don't really understand the disease itself or the treatment options. So the first portion of our training really is culturally tailored diabetes education, and then we bring in the shared decision-making component where they can sort of learn and practice some of the knowledge-based information that they've just received, as well as some of the role play and the skills and the interactive things that we've been trying to promote throughout the class. It's really, the classes are developed really based on adult theory, adult learning theory, so they're very interactive, they're fun. We created a video just for the class, and the 2 pictures you see are taken from that video. We make games and do, again, a lot of role play and use of narrative in that. And I'll go over some of these in detail, but we really found basically improvements in patients' confidence in their actual behaviors as well as their control of their diabetes as a result of these patient classes. Next slide. So this is a table that just shows some of the improvements in the diabetes self-management measures. So we had a measured overall diabetes self-efficacy that we see improved initially and maintained over time, including the 6-month follow-up, and the classes themselves are about 10 weeks. We also saw improvements in other key elements of diabetes self-management, including checking your feet and checking your blood sugars. Next slide. We specifically also were interested in patients' sense of both empowerment and behaviors around shared decision-making. So the first row shows patients' confidence or self-efficacy to engage in the shared decision-making process, which happened immediately after the classes ended. But then we see over the next 3 to 6 months when people actually had physician visits or nurse practitioner visits that they were able to report that their actual behaviors and their physician's behaviors in response to them were changing as well. So they were having more involvement in sharing in the decision-making process in all phases of the shared decision-making encounter. Next slide. We also looked at health outcomes, and you'll see that we saw improvements in the overall hemoglobin A1C in our study population, so about a 0.5 drop at 3 months, and that's about the equivalent of adding a medication. So our classes were as effective as a new diabetes medication, which most people are interested in trying to avoid if possible. We also saw an improvement in HDL, but not the LDL, and we did not see an improvement in systolic blood pressure. We did, however, also measure more global issues around physical health and mental health, and we found improvements in both of those global measures as well. Next slide. We did a lot to culturally tailor the diabetes education program, and I mentioned some of that earlier. And so we did things like really heavily rely on the use of narrative. So we had a lot of storytelling and testifying, sort of using the oral tradition within the African American community. We did a lot of things in group settings. So we developed goals together as a group. We invited people's family and social network to attend the classes, so they weren't part of the research study, but whoever their backup team was who helped them manage the diabetes at home were welcome participants in the class. We didn't encourage people to change everything about the way they eat. We just encouraged them to modify existing traditional diets that really have a lot of cultural resonance to patients. And again, as I mentioned, we created games, interactive games and videos, and the image at the bottom is just sort of an example of one of the cards that we made for our video, for our games, and really linked people into existing resources within the community that they already felt comfortable with as far as being part of their community, but may or may not have known about. Next slide. So I had mentioned that we did a number of different things to underlie the role of narrative in the classes, and so there's actually a paper that we wrote about this. If anyone is interested, the reference is below. But I'm highlighting two comments or quotes that we had. The first was about the video or the film that we made. And one person said, it changed how I interact with the doctor. By me seeing the video, I did have the presence of mind to at least ask, what is this medication for and how often should I take it? And the video is about a 14-minute video that we use in the didactic sessions within the class. The other is about the use of role play. So we had the classes, which are taught by staff and various members of the research implementation team, to have patients actually practice what it would be like to try and engage their physician, who in these scenarios were actually not that interested in engaging their patients. So one person said, they kind of built me up. We'd be like we're at the doctor session, and then she, the teacher, would say things that she knows is not right either, but then she just wants to know, are we going to catch on to it and just let it go, or will we actually speak up? Sometimes you don't want to question your doctor, and it's kind of hard, especially if you really like them and stuff. So she was just building us up so that when you've got to be able to, whether you like the doctor or not, essentially ask them questions and be more involved. Next slide, please. If anyone is interested in learning more about how we actually develop the class, here's a reference for that. Next slide. And also another reference for just in general how we used methods for recruiting and retaining people in the class. We had a really high retention rate. People really liked it, and I talked about some of the elements before, but if you're interested in more details, there's a reference for that as well. Next slide. One of the things that we were interested in from our research team, and that is the purpose of part of what I'm talking about today, is the intersection between shared decision-making and trust as far as patient activation. And what we found when we did qualitative studies after the class was that trust in shared decision-making is really a bi-directional relationship, so that when patients trust their physicians and feel like they have a safe space to talk, that they're more likely to be honest about things that are hard to be honest about, and to really share and engage the physician with their, and talk about their preferences for treatment or some of their reservations or hesitations about the recommended treatment plan. And that also when patients find that physicians are actively engaging them and involving them in a shared decision-making process, that helps to reaffirm and reestablish trust between themselves and their clinician. And also just that race and culture as social and ethnographic constructs mediate this relationship between shared decision-making and trust. Next slide. So the things that we tell our clinic staff who are directly involved in the classes, but just also that are the context in which patients are receiving their care, to try and build a shared decision-making foundation, to try and create an organizational culture that really promotes shared decision-making. So the idea of having physicians specifically say, you know, I want you to be empowered that your opinion is valuable to the healthcare decision, and why that is. We talk about the 3 Ds in the class: discuss, debate, and decide, which really map onto the 3 conceptual domains of information sharing, deliberation, and decision making. And we let physicians and clinicians know that you can talk to your patients and use the same terminology, use those 3 Ds that they've learned in class, so they really know that it's okay, that you actually want them to ask questions because you have validated that experience. The other thing I really want to address for both staff and physicians is that it's really important to address those uncomfortable barriers to shared decision-making, such as trust, cultural differences, and perceptions of discrimination. Those are things that really can be uncomfortable to talk about, but if you can push through them in the clinical encounter, then it really reaps a lot of long-term benefits as far as the patient-provider relationship, shared decision-making, and health outcomes. And again, this is even though we're talking about decisions about treatment choices, it really is not exclusive to the patient-provider encounter, and that we really can engage our support staff. So the presentation previously was talking about community health workers and how they can be a mediator of positive relationships between patients and their physician. And the same thing applies here, that in staff meetings, if everyone is on page, that people can wear little buttons that say, ask your doctor questions, that if there are resources in the waiting room where you can post flyers or show a video, you can have pre-visit coaching by some of the staff to say, these are the, you know, what are the most important things you want to make sure that you ask your doctor about, and how can we make sure that those get addressed, with the use of health educators, or if you have the ability to have a community health worker within your clinical practice. But again, sort of organizing the whole healthcare team to really support shared decision-making that goes on within the clinicians is something that I think is doable and also really important to engaging patients and activating them and building a more trusting relationship not only with physicians but with the whole healthcare system. Next slide. Next slide, please. So I just want to acknowledge the rest of our team and our funders, with that, I'll turn it over.
Great, thank you so much, Monica. That was wonderful. And without skipping a beat, our last speaker is Dr. Megan Lewis, a senior research scientist at RTI International. Dr. Lewis has more than 20 years of experience in both quantitative and qualitative research. She also has expertise in health-related interpersonal communication and has work that has been published in leading journals, funded by the National Cancer Institute as well as the National Institute of Arthritis and Musculoskeletal Diseases, amongst others. And I'll turn it over to Dr. Lewis. Thank you.
I'm so pleased to be a part of this webinar today. So as Dr. Patel mentioned earlier, I'm with RTI International, which is a not-for-profit research institute, and our role in the Alliance was a little bit different than our other speakers. We were conducting an independent evaluation of all the Alliance programs to understand if across particular interventions, grantees, or populations, the Alliance made a difference in important outcomes related to diabetes. So today I'm going to focus on some of the major findings from our cross-site evaluation, which focused on answering the fundamental question, which was, did the Alliance programs lead to changes in important clinical indicators of better diabetes management, such as hemoglobin A1C and blood pressure? And did the Alliance programs enhance important patient-reported outcomes, such as self-managed behaviors, feelings of competence and quality of life that are important for health and well-being and fundamental to people feeling empowered? Next slide. So the Alliance initiative was inspired by the chronic care model, but the grantees made their programs come to life in ways that met the needs of each community and prioritized the needs of the most vulnerable people in their community. In 2011, Noreen Clark and the grantees published a paper in Diabetes Spectrum that illustrated how sites took the chronic care model and applied it to the interventions to fit their local context. So for the cross-site evaluation, we collected data, both quantitative data and qualitative data from sites that were guided by this Alliance model to understand if, in fact, this model was successful at enhancing clinical outcomes and empowering patients. Next slide. We found that across the sites, the percent of patients in good control of hemoglobin A1C and blood pressure significantly improved over time in contrast to a comparison group. We did not find significant changes in cholesterol and attributed that finding to a lack of power in our statistical models to detect any significant difference. We had less cholesterol data to work with because these blood tests are not usually taken as frequently as hemoglobin A1C or blood pressure. Next slide. Using survey data, we also examined a variety of important patient-reported outcomes. Across the board, these measures improved except for smoking. To fit everything in this table, I had to use some acronyms that I'll go over right now. So RSSM refers to Resources and Supports for Patient Self-Management and measures a patient's perceptions of the support and care quality that they perceive from their healthcare teams. It's similar to the PASIC, which is also shown on this slide, which also measures similar ideas. We also found improvements in diabetes diet that are specific about behaviors for self-management, such as exercise, glucose monitoring, and foot care, as well as better nutrition and diet overall. We also found improvements in perceived diabetes competence that measures a person's confidence and competence in managing their diabetes. And we also saw improvements in quality of life as measured by the VR12, which has two subscales that measure both physical and mental quality of life. Next slide. We also collected qualitative data from sites via site visits, document reviews, and interviews with various program stakeholders. We did this at the beginning, at the midpoint, and near the end of the programs to understand the processes that might account for these clinical improvements. So today I'm going to be focusing on the patient self-management aspect of the site interventions that, because there's a couple of points that are important here. One, these patient self-management interventions and programs touched on all aspects of the grantee programs. So it touched on the patients, the providers, the healthcare systems, and the communities in which these interventions took place. We found that an important theme in these qualitative data was an approach that fostered patient empowerment. Patient-centered programs that were comprehensive yet tailored and provided patients with skills needed to communicate with their doctors were very important. Next slide. We also found that access was important. Sites made self-management education easy for people by meeting people's needs. They held classes in different locations and communities to overcome transportation challenges. They made materials accessible by considering literacy levels and cultural appropriateness. They scheduled classes that were convenient for patients. And while this doesn't sound like rocket science, it's very important. They didn't have the attitude, if we build it, they will come. They made sure that they built programs that made it easy for people to participate. Next slide. Social support was critically important as well. Many sites established patient support groups and also invited family members to attend. And this is extremely important because we know family support is very important for patient self-management. In addition, as reported by Dr. Kane, there were more formal sources of support via community health workers that were critical as well. And the community health workers were a very interesting hybrid of kind of informal sources of support because they lived in the communities in which patients lived, and more formal sources of support because they interfaced with the healthcare teams and the healthcare systems. And they became critical partners in the delivery and management and coordination of self-management programs. Next slide. Sites also brought down barriers and addressed community needs to make sure patients were able to engage in the self-management and education behaviors that they were learning. They brought on partnerships so that patients could enact these important behaviors that they were engaging in. So they developed partnerships with pharmacies and YMCAs and food distribution systems so that patients could exercise, eat healthier, and have more access to health care. So they really changed not only patients and providers and health systems, but they changed the communities in which the program participants lived, worked, and played. Next slide. So very important over time was care coordination that supported the patient in the self-management programs. So when we were looking for themes in the qualitative data, we looked at to see if we could find them across sites and across time as a way to kind of make sure that these themes were fundamentally important. Care coordination was a theme that became important over time. We found that by the end of the Alliance programs, care coordination was really the linchpin that was very important for these self-management programs. Sites developed referral systems, contractual arrangements, and partnerships that enhanced coordination. They developed reminder systems. Providers discussed program activities during medical encounters, as Dr. Peek just mentioned, and they used tracking systems to locate people who may not be attending programs as regularly as they should have been. So in doing so, grantees were able to build stronger relationships between patients and providers and enhance those important clinical encounters. Next slide. So as part of the qualitative evaluation, we also obtained information from patients as well on their own experiences in the Alliance programs. We asked them what it was like to manage their diabetes before and after the program and how the program helped them. So prior to enrollment, many patients reported feelings of depression, poor communication, not feeling like they could communicate with providers or that providers could communicate effectively with them. During the program, feelings of emotional support were reported, feelings of getting really good education and information about their diabetes, and feeling a sense of improved communication, not only for themselves, but on the part of their providers. And so after the Alliance, many reported feeling a better quality of life, and really, particularly what was interesting was improved mental well-being. They just felt better mentally as well as physically. And one of the most poignant quotes from these data was a participant who said that this program saved my life. Next slide. So in conclusion, we believe that the Alliance programs and grantees implemented programs that empowered patients and not only changed important clinical and patient-reported outcomes, and the process evaluation identified important practices that can be used by other programs to also enhance patient empowerment and enhance communication between patients and providers in their clinical encounters. And so I could only present a slice of our findings today, but in other analysis we conducted, we also concluded that the programs were cost-effective when they're compared to other healthcare interventions that we typically often pay for in healthcare systems. And by that we mean, like many other interventions, that doesn't mean that there's like a dollar-for-dollar return. What it means is that we get good value for the money we spend in terms of net benefits. And in this case, that means fewer adverse events and higher quality of life. In addition, we also concluded the Alliance programs reduce disparities as indicated by the growing number of patients that met clinical quality indicators for diabetes management over time. Thank you. I'll turn it back to Dr. Patel.
Great. Thank you so much. That's a wonderful roundup, and maybe I can quickly go through a couple of things while some of you are sending them to do some questions. I just wanted to highlight, I apologize that I didn't get a chance to do this. We're going to move to our panel discussion. I just wanted to make 2 points that did not get covered, that some of what we've done to reduce disparities was actually done through the Affordable Care Act's elimination of pre-existing conditions, as well as a number of meaningful private as well as Medicare and public insurance changes to benefit design, namely free access without copays for preventive services for which diabetes-related screenings are critical, as well as a number of other efforts to try to enhance care coordination. So the development of accountable care organizations, the development of patient-centered medical homes, and an emphasis also from the Centers on Medicare and Medicaid Innovation to try to highlight the integration of the use of allied health workers and community health workers and navigators into the care process. I think a lot of what we've been speaking about would not be possible unless some of those changes were also kind of codified into law. And since I kind of speak from a policy and clinical perspective, I think that that's important to say. So we've had questions that came in for our panelists. Let me actually first start with a question that came in for Dr. Kane. Dr. Kane, can you provide, and briefly, I want to be sensitive because we'll end on time, can you provide more detail on the billing codes and cost savings for the community health workers?
Can you guys hear me?
Now we can.
Okay. We, over the course of the Diabetes Equity Project, we started using basic 99211 code for the community health worker visit. But we have only recently been doing that. But because these community health workers are doing blood pressure checks and hemoglobin A1C testing, we're able to bill under those codes. However, the majority of our patients at our clinic are uninsured, and so although we bill, those bills don't really go anywhere. This is a charitable arm of Baylor. But as the hope is that over time, as more patients enroll in healthcare via the exchange, we would be able to actually use some of these codes to reimburse these visits.
Okay, great. And then briefly, tell us a little bit more about the curriculum that they use, the community health workers.
And I saw that the question, I think, is related to what the community health worker used to engage with the patient.
I think so too, yeah.
Okay. So and this is all on that toolkit. For example, visit 1, we go through some basic information about diabetes. We go through glucose monitoring information, so it's highlighted in that toolkit. It highlights exactly what they cover through each step, and it includes the patient education actual materials. We used a lot of information from the Migrant Health Network, which was culturally appropriate and at an appropriate health literacy level, and those are all free handouts. Additionally, we used a lot of hands-on models because, of course, also, as Dr. Peek mentioned, this is how adult learners learn, is getting their hands dirty and touching things and shaking up a Gatorade bottle that's filled with the amount of sugar that it contains so they understand exactly what they're doing.
Okay, great. Dr. Peek, can we get you to answer a question on what tool you use to measure the changes at the 10-week, 3-month, and 6-month follow-up?
Yes, so there are actually a battery of tools. One most prominently is Tubert's measure for diabetes self-care. It comes out of the University of Michigan and is totally free on their website. And so if anyone is interested in our various measures, I am happy to forward them to you. So it may be easier for people to just email me directly or call me because it's not just one instrument. It's actually a number of instruments that we have together. And I'll just say that my email is mpeek@medicine.bsd, like Biological Sciences Division, .uchicago.edu.
Okay, great. So, and then Megan, can hopefully we can get you on audio. I wanted to ask you a question that also is related to some that have come in that's a little bit broader on how some of the efforts kind of around empowerment, access, support, and how you can see that, and some of what you talked about with kind of the alliance model, and how you can see that reducing either healthcare costs or decreasing healthcare utilization overall.
Okay, can you hear me?
Yes.
Okay, good. Good start. So it's a tricky thing with costs, for example. So I think Dr. Kane said that they found changes in utilization but not changes in cost. And it's sometimes very hard to show changes in cost because when you implement programs like this, people actually come in for care. Sometimes more frequently. Their awareness is raised. They feel more empowered to talk to their doctors. So finding those kinds of cost reductions could probably take a longer horizon than we had in our evaluation. So and when you increase access, you might have to put different programs into place. So so we did the cost-effective analysis to try to look at that longer horizon, and so it doesn't look specifically at cost utilization, but it models what you might find over time if these programs, followed the same trajectory in terms of the changes in clinical values that we were finding, and that it leads to the conclusion of decreased adverse events and enhanced quality of life over time, and that they would be cost-effective. So it's a little bit tricky there.
And I think that's what plagues, unfortunately, it's not a problem with just this in diabetes. This has actually kind of been the persistent conundrum around interventions, or at least things that are broader in scale and also take in a multiple number of dimensions, which I think is kind of the complexity you described in your presentation.
Yes, and I think what's important is that we may not find actually a reduction in costs. And so another analyses that we're working on, you'd find a decreased rate in costs over time for sites like this. So
that's a good point. Yeah.
So that's the kind of thing that I think would be a better bar to hold sites to in interventions like this that were very complicated and multi-level, multi-component, and very comprehensive. Is that's what you need to do to achieve the changes that we found. So you'd be looking for decreased rate of costs rather than decrease in costs, absolutely.
Great. Well, we're heading right into the end of the hour here, and I wanted to thank not only our presenters and thank the Alliance as well as the Merck Foundation for support of this effort, but also to remind everyone that the slides and our audio recording with our delays and all can be available on the Alliance for Reducing Disparities in Diabetes website, and you've got the information up on the webinar on the website and the webinar slide in front of you, and that'll be early next week. Thanks, everyone, for your time and your patience, and hopefully we'll be able to reconvene this topic and show that we're making even more improvements as we already have today. Thank you.